Hey everybody, I'm your four-eyed professor, Chris Lievens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Welcome everybody to the Four-Eyed Professor. I'm Chris Lievens. This is our Grand Rounds Live episode, and we're actually diving into a topic area that we haven't covered yet, which is the science and this burgeoning technology and really explosion of technology in the realm of scleral lenses, and the ability that we can, and the issues that we can tackle today we couldn't even touch long ago. And so I imagine that will be a little bit of a hint on maybe where our discussion goes. I'm going to bring up our slides that we are going to be talking through today, as well as our two guests. But before we get started, I really want to take this opportunity to thank Heidelberg Engineering, our partner in this endeavor, and because we are going to be honing in on some of the brand new technologies that they offer with regards to the anterior segment. So first I have with us soon to be Dr. Sarah Sumida, and I have Dr. Brooke Messer. Thank you both for joining us today.
Yeah, thanks for having us. Happy to be here.
As we get started, would the two of you just give us a brief rundown of yourselves as well as your optometry journey thus far?
I'll go ahead and go first. I'm Sarah. I'm currently a fourth-year student at the Southern College of Optometry. I'm in my last, externship rotation and excited for graduation coming up.
I bet.
Congratulations, Sarah. It's always an exciting time, looking forward to what's coming next. I'm Dr. Brooke Messer. I practice in West Fargo, North Dakota at Vance Thompson Vision. We're primarily an anterior segment practice, OD-MD. My journey started at the Southern California College of Optometry, where I went to optometry school, and I did my cornea and contact lens residency there as well. And then I spent just about 10 years in private practice. So I was in a specialty contact lens clinic where we did lots of contact lens clinical trials, scleral lens fitting, orthokeratology, kind of all of that. About 10 years in, decided that my husband and I wanted to get closer to our families with our two children. And so we moved to West Fargo. And then here I joined Vance Thompson Vision, which has been fun. It's been a nice platform to connect with Heidelberg. And so that's how I landed here today.
Perfect. Well, thank you both. So audience members, thank you all for joining us on this journey of Grand Rounds tonight. Sarah is our student doctor, soon to be real optometrist, and she is going to be presenting a real life case that we will then get Dr. Messer, Brooke's insight on, because she is our resident expert in the realm of anterior segment, in particular, scleral lens technologies. So Brooke, we will be back with you in a moment. Hang tight. And now this is time for Sarah, you and me, to tackle this real patient case. So walk us through this interaction that you had.
Sure. So we had a 58-year-old female patient come into our contact lens clinic. She was just in for her annual exam. She had noticed some increase in blur just in that left eye. Over the past several weeks. You can see that her ocular history is significant for PKP in both eyes back in the 90s. She had keratoconus and had some scarring. And then in 1999, she had a repeat PKP of that left eye. So she's, had graft rejection before, had to have that repeat. And then kind of in 2011, she was only corrected to about 20/60. And also still had some corneal scarring. So she was referred for a low vision evaluation and then eventually ended up in some scleral lenses around 2014. And then we saw her, recently. So she's been happy in her lenses.
So in my career journey, Sarah, back in the 90s, I had an opportunity to work in an anterior seg ophthalmology practice. And so, PKPs were, commonplace to deal with. And where where we are today is really reflective of the patient's journey that we're talking about this evening, in that it really wasn't a matter of if a graft is going to reject. It's a matter of when we think this graft is going to reject. These just were, as successful as they could be given the technologies of the time, but patients really were suffering from poor vision, discomfort, litany of ocular medications to try to prevent rejection, even though they really didn't work that well. But now, with the technologies that we'll be talking about this evening, significantly better. So as you saw her with her current sclerals, walk us through some of the early testing data that you were able to capture.
Sure. So she is best corrected to 20/30 in her sclerals, which I think is great compared to the 20/60 that she was without them. And she's very happy with that vision, near about 20/40 with her over-the-counter readers. And then we were doing topography every year on her just to make sure there's no, any edema or any progressive steepening, any changes to the regularity of her cornea from there.
I remember when you and I first started talking about this case, and the first thing that jumped out at me was the vision with her current sclerals at 20/30 is remarkably well. Again, back in the 90s, if we got a vision of 20/70, that was a success. So it just goes to show the ability to create essentially artificially with the lens a actually natural curve, and not with a great amount of irregularity, can deliver really fantastic vision.
Yeah, absolutely. And the patient's very happy as well, compared to the 20/60 that she was without him.
Sure.
So we kind of talked to her a little bit more. Upon further questioning, we found out that she had stopped the steroid that she was supposed to be on because she is prone to this graft rejection. She was on a daily steroid. And so once we found out that she had stopped that kind of threw up a red flag for us to kind of, look at that left eye a little bit heavier.
Why do you think she stopped the steroid? I mean, most of the patients who have any type of a transplant understand that though they may be immunocompromised, that they really need these medications to prevent the body from fighting off what is really an artificial new part of them.
Sure. I think it's also very patient dependent. This patient had a hard time remembering things. She had a lot going on, systemically, nothing recent, but, a lot to keep up with. And so I think it's sometimes hard for them to understand the importance of just the daily drop and the effects that can have when they don't use it.
Yeah, understood. What'd you find in the slit lamp?
Slit lamp. So the right eye looked pretty good. Some neo, pannus, but what we were really looking at was that left eye because that's what she was complaining about anyways. So we saw some corneal haze centrally, paracentrally, and we could also see some of that edema in the cornea as well.
So on the right eye, the eye that really not really worried about, one thing that catches my attention is looking for pannus and looking for neovascularization. And what I've found over the years is just when somebody takes a visual glance, unless this is part of their daily routine, they tend to overestimate the amount of neovascularization as opposed to underestimate it. Because when you actually do take the millimeter rule on the slit lamp and actually measure it physically, I think we're often surprised by when you actually have a significant amount of length to neovascularization in terms of the vessels, it visually looks wildly large and long. And so sometimes 0.5 can actually be quite normal and actually not necessarily pannus when we actually measure it. But of course, you were actually focusing your majority of your attention on the left eye. In this case, could you describe what the corneal haze looked like to you?
I mean, it was pretty diffuse throughout the central cornea. It was a little bit hard to see through it, to be honest, from what I remember. So it was, a little bit more significant than just, your mild corneal haze that you might be able to see through and you could just easily miss.
So this would not be something that you could have overlooked?
No, definitely not.
Got it.
Here, just her habitual contact lens parameters. She was in the Jupiter lens, and these are the lenses she had been in for years. The fit was great on them, and there was really no significant issues with the fit of the lens itself at this point.
Yeah, so we're really a matter of, in this case, we have an eye that's doing remarkably well based on the vision that we had. All is stable, not a motivation to change anything in terms of the lens fit, right?
Yeah, exactly. That's a great point.
And when you say no significant blanching noted, what exactly were you looking for there?
So, we were looking at the edge of the lens, seeing if, it was too tight, because that could really cause some issues, needing the blood flow, to the eye.
Yeah, makes sense. So I'm going to bring Dr. Messer back, but she's going to walk us through some images that she shared using Heidelberg's Anterion OCT, an anterior OCT that's newest to market. And you can see right out of the gate, the visual depiction of anatomy is stark in terms of its difference to things that I've used in the past. It's remarkable, though, that we're even able to come close to this. It's really impressive every time I see it. So walk us through these, and I'll be happy to move the mouse cursor for you through the slides.
OCT from Heidelberg. And for those of you that are, coming into the optometry space, learning more about all the instrumentation out there, Heidelberg is really known for resolution, which, you can see here. So this is a DSEC. And when you look at these endothelial keratoplasties and you're comparing, like, am I looking at a DSEC or am I looking at a DMEC? A DSEC is going to be a thicker tissue, and there's a defined line of adhesion between the posterior graft and the stroma, and you can really see that here in this image, where the DMEC really just kind of blends into the cornea, so it would be easily missed on even an anterior segment OCT. On a slit lamp, you would see the DSEC a more perfect circle, where the DMEC kind of blends. It's a little bit harder to see. So this is a great looking DSEC. You can see how nice and clean the tissue is, adhered to the host stroma.
Was this a custom scan, or was this just a built-in scan that you could do on a daily basis?
This is probably just our custom scan, probably the Metrics app. I don't quite remember, but no, this is maybe the imaging. So the Anterion has a couple different modules. There's a cornea module, a cataract module, an imaging module, and what we call a Metrics. And I'll for sure discuss which it is. The imaging module, it just has that starburst pattern, and just gives us maybe 8 to 10 B scans there. So I think that's probably what this one was. We use that scan with a bunch of different cuts, so that we can kind of get a really good look at that graft all the way around to make sure we're not missing any places that the graft might be separating.
Yep, makes sense.
Here is a DSEC that is not adhering very well. So you can see that little bit of tissue separation there, which would be the nasal side. This patient was having some symptoms of microcystic edema or bullae. So there is even a BCL in place, which you can see on the front there. So you can even visualize how thin those are.
We really, on this technology, get a really wide scan to be able to visualize from one end of the edge all the way to the other, which is, remarkable to me.
Yeah. This one here is something that in a patient like the two of you have been discussing, that we do in our clinic sometimes when we have somebody who has a PK that's a little older. We can get a baseline pachymetry and then get a pachymetry, say, right after their lens comes out, and then create a difference map so that we can see if the cornea is tolerating the lens well, and if not, where that hypoxia-driven edema is showing up underneath the lens.
So from the 2-year perspectives, when it comes to looking at changes in pachymetry, presumably due to some corneal edema, what types of values cause you to be on alert?
I think some of it depends on, here, we were looking at 19 microns, and I wasn't really overly alarmed there. The studies show, 2% or 3% of overnight edema just in the closed eye state. I think, to me, I would be more looking at lines of lost vision,
Sure.
and then going from there. again, I wouldn't say I have like an absolute value. So maybe I'm not the best there. There's just so much science out there on edema. I feel like if I say something that somebody with a bunch of papers is going to come attack me, but because I'm more of a, I'm definitely more of a clinician versus, all the research. But, I would say I'd start to get concerned around like 40 to 50 microns or something like that.
All right. Sarah, is that your perspective too?
Yeah, I would agree. I agree that also, with the changes in vision too, it's a better way to tell kind of the impact it's having.
And we're also looking at, endothelial cells too. So we often pair this with those ECC type scans to see what's going, to put a more full clinical picture together.
So just to understand what you might suggest be the approach to care on a patient who's had a PKP, they're back for a follow-up, may not have any complaints per se, and their vision is stable. Would you still run them through these scans and assessments, in this case, pachymetry, or would you really gear that towards a patient who's had new complaints or loss in visual acuity?
I mean, I actually think having these types of scans when patients are asymptomatic is gold, because now when they come back and say, I am symptomatic, if you run this and it's about the same 2 years later, then it helps you, maybe it's something else and it's not the cornea versus just, it's just assumption that the cornea is, failing, decompensating, whatever, where it's like, well, actually the cornea is no more swollen than it was 2 years ago when you were doing great. So now I need to keep looking. So having asymptomatic baselines is super helpful in all things. Even on my new scleral fits, if I have a graft in and there's, a hint of, neovascularization or beefy vessels, a thick graft-host junction, even a little bit of, a little haze around, something, all of those are great baselines to have as a color photo as well, because you don't want to be sitting there a year later wondering if that haze was there when you started, because we just won't remember. Even though it looks normal, anything sort of atypical is worth photographing.
Brilliant. That's our first big take home of the night, Dr. Messer. Don't let
baseline photographs. Yep.
Don't let these technologies that are giving us a wealth of information collect dust. That's not what they're intended to do. Also, don't wait for complaints or things to go downhill to try to figure out where you ought to be. Do test asymptomatic patients that will only reward you with good data later.
And the one thing I can say about the Anterion is, one, when you work in a clinic, when you have a team with you, so many of you will have technicians in your clinic. My team absolutely loves the Anterion. It is so fast. It is user-friendly. It's easy to position the patient. They don't have to be, near or far. That's easy to get them chin and chin rest, all of that kind of thing, versus, visual fields where the foreheads and all the alignments and things. The Anterion is so easy to use. And you also have the computer screen to the side, and the patient love the pictures of their corneas. So it is definitely a team and patient favorite.
Yeah, I wrote down a couple of bullets that I definitely wanted to share with regards to what helps make this technology be so unique. And I wrote that the Anterion scans are 16.5 millimeters across, 14 millimeters deep. That allows for a 360 view of the scleral landing zone when it comes to fitting sclerals. And the imaging is available through targeted swept source at a wavelength of 1310, which is really helping give us what we're seeing here.
Yeah, the other thing that's helpful, you can go to the next slide, is you can see through haze sometimes too, where other types of imaging you may lose the quality of something behind it, where in this picture here, this is a second corneal transplant on a patient like yours, but not the same patient. And you can see that centrally, it actually looks like the scleral lens is vaulting her cornea pretty well. But if we only used like the anterior segment little like add-on to the posterior segment type of device, I would get that central 8 millimeters and be like, oh, look how pretty this vault is. It's even across the central 8, not even realizing that my lens is much too prolate. If we think back to, early optics and contact lenses, the center is prolate and this eye is pretty oblate. So we actually, in this type of eye, we would want to flatten the base curve a bit so that we can actually lift that mid-periphery over that graft-host junction, in addition to probably deepening the seg just a little bit overall, so that we can get out past that mid-periphery. And so this is where having that full 16.5 millimeter scan. You can see that I can see edge to edge here on this lens. Pretty well aligned once we, land out on the sclera, but we definitely have some work to do over the cornea.
Yeah, I think that's take home number 2 for tonight. That technologies that we would have been employing in our recent past could easily have misled us to think this was a win.
Mm-hmm. Here is a really complicated patient with aniridia. This is actually acanthamoeba, post everything, probably her 5th corneal transplant, super oblate eye. And so we have a super oblate lens. The scleral lens is, I think, a base curve of like 21 or 27, something like that. Which is why we have that little hitch on the front part of the lens to just try and maintain center thickness. However, her cornea still couldn't tolerate it. So we can even see that there's those little microbulae on the anterior segment or anterior part of the cornea. So eventually this graft failed too. But again, you can just see the high detail of everything that this imaging does. And I just feel like the anterior segment OCT, now that we have these big wide scans, and it's not just for sclerals, being able to see the entire chamber on so many types of corneas has really changed the way that I use anterior segment OCT. Before we had the Anterion, I would say I don't know how much I would touch it other than troubleshooting maybe a DMEC, where now it's just part of my daily, I use it for so many different types of eyes. Here's just an ICL measurement, so we can get down. This is the metrics module, so we can use a little caliper there to measure the vault over the crystalline lens. And my surgeon likes to say, small vault, small problem, big vault, big problem. So there's another take home for you all. Ideally, we like, vaults maybe a little bit more than 300, but not going to lose a lot of sleep over this one. It looks good. Again, small vault, small problem, monitor periodically. But a great tool for this as well.
Yeah, makes sense.
This one I called the mother of all Salzmann's nodules. It was something like 600 microns thick. And again, just another neat, you can even see the tear layer there as it kind of evens out her center cornea. And just a good image of, again, you can even see through the opacity of the Salzmann's nodule there to see how thick her cornea is underneath. This is just another example how before we talked about a lens that was too prolate over an oblate eye. This is a lens that's too oblate over a very prolate eye. So this one would do better if we had maybe a smaller optical zone with a steeper base curve so that we could really kind of wrap around that cornea and prevent mid-peripheral, midday fogging and things like that, just to optimize oxygen, align the tear layer for just an overall better fit.
So seeing a patient like this, and then the other one that you mentioned before, of course, the other one was an incredibly unusual shaped cornea. This one is also unusual, but to a lesser extent. Yes. So you have a patient like this, and maybe on the day that you're seeing the patient, they're not having a complaint. Their vision hasn't changed. The surface anatomy appears to be undeterred, but then you do this scan and realize that at least scientifically, the lens design is not optimal. Do you make the change to an optimal design, or do you wait for an issue?
I would say it depends on where I'm at in the fitting process. Like if I'm still early in the fitting process, then sure, I would change it and optimize it a little bit. I remember back to when I was first fitting sclerals. I did my residency in 2010, and how many fits were terrible. Like back then we were taught to fit with at least 500 microns of vault, where now we're more like 200. Again, patients did really well. I think somebody like myself who knows how to manipulate all of these things and likes to get these picture perfect images, I would pursue a change if I was still in warranty, but I probably wouldn't make the office that I work for or make the patient pay for a new lens just because this picture isn't textbook perfect. It would be appropriate to maybe monitor every 4 to 6 months, just make sure that everything's going okay. And then as you refit lenses year over year, just inch it in the right direction every time.
So we had a question pop up that you could hear on the screen from Bria. What are both of your thoughts?
The oblate lens over the oblate eye would undergo graft rejection post-PK. So what do you think? Do you want to comment, Sarah?
I was curious to see on your opinion first.
Okay, so the lens the oblate lens over the oblate eye, really tough case because of all the things that her eye has been through post acanthamoeba. Her eye just is her whole eye is failing, so it's really hard to keep anything going, to be honest. So had that been like a fresh PK on, say, maybe somebody who had keratoconus, probably a much better outcome. But in her case, she's had so many grafts and her tissues are just so beat up from all the suturing, and she has like scleral patch enhancements, patch grafts and everything. So her eye is a really challenging one. And so it's very delicate. We have since moved on to corneal GPs, and we even have a hard time with tolerating those too. So just a tough case overall. Definitely not the norm, but I absolutely love how perfect the lens cornea alignment. That was one of those where it's like, if we can't do this one, like no scleral is going to work here. But definitely not the norm.
Yeah, but it's not the oblate or the misshaped non-optimal lens that's causing the issue. The eye is that issue all by itself.
Yes, her eye. I mean, it may have failed had we done nothing wrong. Like if it was perfect outcome, no lens introduced. But it's a tough case where, I mean, she's essentially monocular as well. Like her other eye has issues, and that was her better seeing eye at the time. And so lots of stuff going on in that patient. Oh, this is just a pretty picture of a DMEC that decided to separate, and you can see all that corneal edema from the endothelium peeling away. Just again, to highlight just the beautiful resolution of this device. This one highlights epithelial mapping. So this is one benefit that anterior segment OCT has over tomography, is that we can image the epithelium. And in this case, so let's take our eyes to the top left image where we have the tangential curvature. So this is what we would see on just a regular topographer. And we see that inferior steepening there. We have like Ks approaching 47. This could be a KC suspect. We look at the posterior elevation, top right, nothing too exciting there. Pachymetry is roughly normal, just about 550. And then the bottom left is the epithelial thickness. Hot colors is thin and warm colors are blue. And with patients who have keratoconus, the epithelium actually thins over the apex. And so we would anticipate, warm colors over the apical area of a mini cone or a hidden cone, if you would. Where in her case, she actually has epithelial thickening in that inferior area. And so she's actually getting false steepening due to thick epithelium. So the anterior segment OCT is really nice to be able to help us differentiate, okay, we have this like kind of asymmetric cornea finding with this inferior steepening. Let's say she's wanting to have LASIK. We have to decide, can she have LASIK or not? And this, to me, because of that like focal epithelial thickening, I'm thinking she maybe has like low-grade basement membrane dystrophy, even something like low-grade Fuchs, where there'd be just a hint of swelling maybe somewhere. And even they say that the epithelium can migrate with just the blinks, and just kind of that epithelium is a little thicker right at maybe where the upper and lower lid would meet, and we can see some epithelial thickening there too. So probably not KC, but something else that may be worth diving into if this patient was pursuing LASIK.
I could see with technologies of the past how easily this patient could have been confused for having keratoconus for many years, quite frankly.
Yep, and may even have KC-like symptoms. Like there certainly could be some coma there, but perhaps what she needs is like a PTK or an SK, actually.
Mm-hmm. Mm-hmm. So before we dive out of this, I think that was a great overview of what the Anterion can deliver. You were going to mention to us the attributes and the go-tos on I think it's the metrics app, the imaging app, the cornea app, etc.
Yeah. Yep. So in my practice, this one here is the cornea app, and it has tons of different images or tons of different little pictures that you can pull up. The list is probably like 10 or 15 long, and you can create your own little programs like that one. That little setting for us is our irregular cornea screener. But you can do a 4-map refractive that you get with a pentacam. You can set it up, however you want it. You can have like a LASIK setting, and then you can pick, there's ones, it can show you corneal aberrations. And so you can set it up to however you think it makes sense in your practice and have these little preset settings under the cornea module. Same with the metrics. It can give you the raster. It can give you the starburst pattern. My favorite on the imaging one is just the 16.5, like you said, 16.5, about 12 cuts, so that I have this really dense star pattern. And that's what I use to look at scleral lenses, because I just want to see like, where are my asymmetries? I want to capture most of what that lens is looking like, versus just doing like, north, south, east, west. There's just so much in these fittings because the eye is not, a perfect circle. So we need to be able to see it all. And then the, what am I missing? The metrics app, that's what we use for measuring ICL vault. Sometimes I'll use it for scleral vault, but personally I feel comfortable just eyeballing it with the imaging app. You can also, it can also do like angles if you were measuring it from a glaucoma perspective.
Fantastic. All right, so back to our case, Sarah. Well, bring us back to your assessment at the time you saw this patient.
Sure. So we have the keratoconus, and we also have, the PK with the recurrent corneal haze in that left eye. And we came to the conclusion that it was, likely due to the noncompliance with the steroid, which we kind of talked about already. And so we really emphasized with her the importance of using that steroid because she is such at a high risk for, the graft rejection, considering she had already had it once before. So kind of, it could be one of those cases that you talked about earlier, where the eye just keeps having rejection after rejection. We just really didn't want her to be in that kind of situation.
Right. So it's hard with patients. Like in this case, Sarah, you attributed that for this patient was seemingly forgetful, and maybe that was the reason. And maybe the strategy is finding new ways or new people or phone alerts to remind or place the bottle in a different spot. Sometimes with patients who get off medication, sometimes I suspect, well, maybe it's an issue with the medication. And in this case, we're talking about a steroid. So a lot of the steroids have gone generic. Some generic steroids cause some problems. They can crystallize in the tears. They don't suspend very well, despite a lot of shaking. And the drop itself can be uncomfortable and can actually be demotivating its use on a chronic basis. And so sometimes just changing the med can be a strategy. Dr. Messer, what types of things do you think of for patients who are just getting off of what they need to be on?
Patients have a hard time sticking to drops. It's just the way it is. We tend to hit pretty hard with, things like difluprednate early, Durezol. We don't get too scared of, pressure spikes or anything like that. And I do feel that like hitting it a little harder, a little bit more aggressively in the beginning sometimes keeps it happier for longer. The other thing to think about is, I guess, is that what you wanted to cover with the drops? I was going to go off on a whole transplant tangent. I'll let you manage the time.
Got it. All right, so back now to our plan.
Yep. So we updated her, glasses, contact lens, and again, just re-educated on the importance. I think also on top of that, some patients, kind of like we said earlier, they don't understand the importance of it. They don't feel these things sometimes, kind of similar to glaucoma drops. Without the education, they don't, feel any kind of changes that could be happening for them. So really re-education is key in this case.
And sometimes once they get out to that, like every 6-month follow-up, they kind of think like, oh, I was given, a clean eye bill of health, therefore I can just stop my drops. That's what we encounter a lot too. And even though we tell them like, do not stop this unless we tell you, which is usually never. So you need to get a refill every time you run out, or they just, same thing. They think they just run out and then they're done. So once those follow-ups get longer and longer, that's when we start to really lose that compliance.
So based on what Sarah did, Brooke, give us your perspective. So you have a patient who's doing well, seeing well, the lens seems to be fitting well, and they need a new lens maybe. Do you keep parameters? Do you go back to square one again? What's your strategy to bring a new lens to the situation for an eye that's doing well?
Okay, for an eye that's doing well and the lens looks like it's fitting well, I would start with a duplicate, even if there was a small over-refraction.
Okay.
We know that GP lenses can be modified just by cleaning. We can move that soft plastic, and so it would be difficult to duplicate the lens as it stands when it's 3 years old. So I would start with the base lens that I know rather than chase any sort of weird over-refraction, especially if it was like astigmatism or something like that. And then whereas if let's say they over refracted with say like a -1, maybe I would give them just -0.5, like inch in the right direction, but we might end up chasing our tail.
Would you do differently if it was a hyperopic shift as opposed to a myopic shift?
A hyperopic shift, it would be harder to do that because you'd have to push plastic to the center of the lens. So I may look at that more intently, I guess, but most of the time, to be honest, like if it's, a lot of times these patients with PKs have had cataract surgery already. And so most of the time we see a myopic shift because of the slight warpage to the lens. However, if it was hyperopic, again, I think it depends on patient complaints. Anything less than +0.5, I probably wouldn't even touch it.
Got it. Makes perfect sense. All right. Now time for our raffle. Thank you to everybody who's attended this evening. We picked 3 winners in attendance to get a $50 Amazon gift card. The Defocus Media team will send you each these gift cards, usually within 24 hours. So our first winner is Madison Rico. Our second winner is Bria Maddox.
Woo!
Our third winner is Stephanie Ha. Congrats to all, and be on the lookout for your major awards. So thank you, Sarah, soon to be Dr. Sumida. Thank you, Dr. Brooke Messer, for sharing your insights with you on this evening to dive into the realm of the Anterion by Heidelberg, as well as the technology of scleral lenses. Thank you from the bottom of my heart, Chris Lievens, a 4-eyed professor, and please follow us, Defocus Media, for more spectacular content. Thank you for sharing your time with us tonight.
Can I say one thing?
Yeah.
We have a residency here, and so if anybody is inspired by what we have tonight, there's still time to get your applications in.
Yes, go for it. I have plenty of podcasts on the importance of an optometric residency. So flash back to my library and you'll hear me say over and over and over, apply to Dr. Messer's today.
Yep. Just shoot me an email.
Class is ended for today, and we have no exams or grades approaching. Please email me at 4eyedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.